Welcome back to Cancer Buzz TV. I'm your host, Summer Johnson. This is the second episode in our three-part series on how to manage challenges with relapsed refractory mantle cell lymphoma. We know BTK inhibitors and CAR T-cell therapy can improve patient outcomes in the long term. But first, patients need access to these therapies. Here to discuss the role of each therapeutic strategy are Dr. Nirav Shah, an associate professor of medicine in the Division of Hematology and Oncology at the Medical College of Wisconsin in Milwaukee, and Dr. Kirollos Hanna, director of pharmacy at Minnesota Oncology and assistant professor at the Mayo Clinic College of Medicine in St. Paul. Thank you both for being here. Dr. Shah, how do frontline therapy choices impact the subsequent treatment landscape for patients with this disease?
Absolutely. So when I meet a new patient with mantle cell lymphoma, I'm looking at many different features of both the patient and the disease. The predominant one is age and fitness. Younger, fitter patients, we offer more intensive chemoimmunotherapy combinations. And for older patients, frailer patients, those with other medical problems, we're offering them milder chemoimmunotherapy combinations. And so that's one of the big differentiators about in terms of what we think a patient can tolerate. But there's also disease prognostic indicators. And one of the things that we look at now is the presence of something called P53 mutations. And for those patients, we're learning that chemoimmunotherapy may not be the optimal treatment choice and considering more novel agent-based induction therapies. And so what we try to do is look at the disease characteristics and the patient characteristics and make appropriate upfront treatment decisions with the patient that best fit that particular situation.
How do factors like gastrointestinal, hematologic, and cardiac toxicities guide the selection between BTK inhibitors and CAR T-cell therapy in relapsed refractory cases?
Yeah, so, vastly different treatment experiences to go on a BTK inhibitor versus something like CAR T. A BTK inhibitor is a pill. It's generally very well tolerated. You highlighted some of the known side effects. Some people can get things like arrhythmia, atrial fibrillation. Others can have increased risk of bleeding or increased risk of infectious complications. But as a class, BTK inhibitors are very well tolerated and can be offered to almost any patient, even at the extremes of age, patients in their 80s or 90s, or those with many medical conditions that may preclude them from getting an advanced therapy like CAR T. Now, CAR T cell therapy is also improving. The newer form of CAR T that was just FDA approved has an improved safety profile, which will allow us to administer it to patients that maybe we didn't think were candidates for the other CAR T that is currently available. And it's nice to have more than one option available to our patients. But regardless, CAR T has more risk. I tell my patients that there is about a 5 to 10% risk of having a non-relapse related mortality event, meaning dying of a complication, either directly or indirectly related to CAR T, because it does immune compromise patients. You do get chemotherapy with it, and you have that risk of sort of that acute inflammation that happens. And so CAR T is my go-to for younger, fitter patients that have progressed either quickly, have high risk features, or have failed a BTK inhibitor. And BTK inhibitors are my preferred choice as a second line therapy because there are patients who can get a long duration. And definitely for my older, frailer patients, I might go from one BTK inhibitor to another BTK inhibitor if we continue to see efficacy. Ultimately, though, most patients will see both of these treatments because it is unclear yet if any of these treatments actually lead to a cure, which has been an elusive word, unfortunately, in mantle cell lymphoma.
Dr. Hanna, what's the exclusion criteria for patients who may have active or serious infection?
Yeah, so exclusion criteria for CAR T cell therapy, it's really going to be driven by access and also the patient's status. So are they frail? Do they have comorbidities? Do they have pre-existing cardiomyopathy? And oftentimes, I think when you look at the mantle cell lymphoma patient, this is an older population. We're generally diagnosing these patients in their mid 60s to late 60s, early 70s. And then that just, the disease by itself comes with various comorbidities that are tied to that patient's older age. So I think those are really key drivers. We also look at how well the patient tolerated frontline induction. We're not really seeing a lot of CAR T cell therapy move in the frontline setting just yet, while there's a lot of ongoing clinical trials, which we'll get into. But really right now, it's going to be that patient characteristic, how well they did on frontline therapy, access to care, affordability, institutional preparedness, and then that would potentially, allow your patient to receive CAR T cell therapy. But when I do see these patients who are 70s to mid 70s and have a lot of comorbidities, that does tend to be the key driver of exclusion for CAR T cell therapy.
Dr. Shah, any final comments?
I would say that the most important thing to me is collaboration. Most patients with mantle cell are treated in the community, appropriately so. I work at an academic center. I see the mantle cell lymphomas that have failed other treatments. And that's good because we have things we can offer here that are not available in the community. But the key to all of this is good collaboration between the community and their affiliates, right? Their partners in academics or tertiary referral centers to really engage on these patients in a collaborative format. Because it really takes a team, a village to take care of complex mantle cell lymphoma patients. And even after CAR T, patients need to go home. And so, we need providers who are going to be engaged and be able to take care of these patients and deal with the complications that may occur after CAR T and be willing to ask for help when that help is needed. And so we have an excellent group of community doctors here in the Wisconsin area. They have my cell phone. I have their cell phone. I called a guy this morning to talk about a mantle cell patient that we share and to come up with a treatment plan again in a shared decision-making fashion. So I think it is important to obviously have shared decision-making with patients, but it's also important between different providers because we all work together as a team again, to take care of these patients who are dispersed across, right, the United States. Not everybody lives next to a big city.
Thank you for being with us. You can visit the show notes for information on the topics discussed today. And make sure to follow this channel on your favorite podcast platform. It's the best way to know when our next episode is live. While you're there, you can look for other episodes on topics that you might find interesting and useful. Until next time, from all of us here at Cancer Buzz TV, thank you for watching.